easier. I'm going to talk about marginalization, finding your voice. How many, I'm just curious, how many in this room understand what marginalization is? Is anyone? It's relatively new, at least I think it's relatively new, but I'm beginning to hear more about it in the, on radio, on TV, they talk about how to make it marginal. So hopefully, I'm going to give you some insight into exactly what marginalization is. Just to give you a little background on who I am, I was born and raised in the Chicago region, okay? Chicago, yes. Went to Michael Reese Hospital, became a nurse, okay? And only thought I would be a hospital nurse, a med-surg nurse. Had no intention of going any farther, but I just wanted to be the best that I possibly could be. The problem is, I really don't like hospital nursing because I'm a health promotion, disease prevention person. I want to keep people out of the hospital. And so back in the 70s, back when it was a pilot program to see whether or not Indiana University wanted to bring family nurse practitioner into the university, I went to a pilot program. Up in the Chicago region. And it was a great program. And then a very intense program often. And afterwards, because it was so intense, took my family on vacation to the Smoky Mountains. Okay, down by Gettysburg, a beautiful area, God's Green Acre. Only with the intentions of going up there and then coming back home. But in the process, they needed a nurse practitioner in Crab Orchard, Tennessee. Little town of 1,000 people. And I found out about it while we were on that vacation and then promptly went home. But the nurse practitioner was not in that office that day. The realtor, we were looking at some land in that area because even though we were only 30 years old at the time, we thought we would retire to Tennessee. So we were looking at some land to buy for our retirement. And so when I went to the realtor and told her that, she said, oh yes, and what kind of work do you do? And even though I had never worked as a nurse practitioner, I identified as being a nurse practitioner. I'm a family nurse practitioner. You probably never heard of those. They're relatively new. You know, back in the 70s, they were very new. And she said, oh, we have one right down the road in Crab Orchard. She said, and Tennessee, in the rural areas, I mean, they use nurse practitioners quite a bit. And she runs out, goes out and gets Katie's name and number, comes back in and says, here's Katie's name and number. When you get back north, write her or call her. Of course, no one called back then because it was so expensive. Can't you remember 3 minutes? We talked about everything in 3 minutes. Because it was very expensive. So I wrote her a letter. Within a week, I had a response to that letter. And in my letter, I just said, you know, I'm a nurse practitioner. I hear that you are one. I'd like to know what you're doing. And do you think down the line, I'm thinking 30 years down the line, do you need another nurse practitioner in your area? And she promptly wrote a letter back and said, Dear Ann, I've just given my notice of resignation, and I believe the Lord has you for my job. So I went down, my daughter and I, my first grade daughter and I drove down. I interviewed for the job with the doctor and the community. It was a community health clinic, so I met with the board of directors. And I came out of that meeting saying, well, now do I have the job? And this was the last week of June. And they said, I'm sorry. If you know anything about rural people, okay, very clannish. And their response is, I'm sorry, we're looking for someone local. So the next day I went out and bought a house. And now I was local. I said, you know, I called my husband. He says, well, buy the house you want because we'll be there for a while. So I bought the house without him seeing it. Took a picture of it. Went back north. Started packing up our house. Put the house on for sale. And every week I would call back and say, do I have the job? And every week I get the same response. I'm sorry, we're looking for someone local. And so by the middle of August, because the woman, the practitioner that was there, was leaving September 1st, by the middle of August they told me I had the job. And so we packed up the car, sent on our way, and I spent 20 years in Tennessee. Okay? All right. My husband and I had never talked about moving away from the Chicago region, didn't think about it. But I'm telling you, when the Lord has plans, go where He wants to go. Who would have thought? I mean, you understand, I met with my nursing friends at that time and told them I was going back to school to get my nurse practitioner, and they all told me that I was crazy. I was throwing my nursing career away. Doctors would not let me do what I wanted to do, and nurses would not let me do what I wanted to do. I wanted to teach health promotion and disease prevention. My goal was to keep people out of the hospital. But in retrospect, it's been a phenomenal journey. I've been a nurse for 42 years, a family nurse practitioner for 34 of those years, and it's been an awesome journey. Now, once I got to Tennessee, you know, even though we had come from Metro Chicago, I mean, what a rude awakening to go to the Cumberland Mountains, okay? The Cumberland Mountains, the foothills of the Smokies. And when they talk about Appalachia, they mean Appalachia, okay? But the Appalachian people are also a very strong, a very independent people, and I love them. Okay, we loved it. It was a great place to raise our children. And we stayed there for 20 years, never talked about moving away from there. But in 1999, the government had decided that anyone who did not have their master's degree could continue working as a nurse practitioner, but the government would no longer reimburse you. You could not be reimbursed for Medicare or Medicaid. And 45 to 50% of our clientele were Medicaid. So I went back to school to get my master's at the University of Tennessee. And only with the intentions of getting my master's and going back into clinical practice. But while I was there, I had a patient who changed the trajectory of my life. Because I had done so much prenatal work, and when I went back, I went back to get my women's health nurse practitioner rather than just my family nurse practitioner, since I already had my FNP. But anyhow, so they put me in a high-risk OB area because, you know, I'd done so much prenatal. But anyhow, I had a young lady come in, about 25 years old, well-dressed, happy-go-lucky, looked at her history, and it was, you know, nothing out of sorts, okay? So I started the physical exam. Everything was going well until I got to the pelvic exam. And in the pelvic exam, she went ballistic on me, started getting hysterical, crying, just coming off the table. And so I had to stop my exam and explore with her what was going on. And she was having recovered memories of childhood sexual abuse. Well, it happened to hit at the time that I needed a nursing issue paper, okay, and presentation. It's amazing how what's required in school, you know, dovetailed with what was happening in my clinical practice. But anyhow, you know, I worked with the lady, we got things in order, we got her some resources. But when I thought about the presentation I needed to do at the end of the semester, I decided to make it looking at research of what's been done with women with a history of childhood sexual abuse. I was amazed at all what I found. Okay? And so I gave my presentation in a group of about 17 nurses around this conference table. And then after my presentation, there was a question and answer period. And 15 of those 17 people either had a personal issue with it, a family member, or a very close friend. And so that's what it felt like at that time for me, because I felt like it was a bolt of lightning coming down from God saying, and you're going to spend the rest of your career doing research in this area. Now also at the time that I was there, I was learning about abuse in women, but then I also had met Dr. Joanne Hall, who back in 1994 had written an article about marginalization. And when I read that article, it was like someone opened my eyes to see a whole new thing. And how people being marginalized, women being abused, it all dovetailed together. And so it was really what my research, the program of research has been built on really what I had seen in clinical. And now for the last 12 years, I've been doing research in that area. So I'm going to sort of give you an overview of that research, and I'm going to try to explain to you what exactly marginalization is. Because once you learn about it, you're going to be amazed as to how often you see it out wherever you are, whether it be in clinical, even in being marginalized as a nurse sometimes in the decision-making at your hospitals or in your clinical setting. So hopefully by the end, you'll understand marginalization much more. Now, I've been accused of being a storyteller. So a lot of times I'll get a little sidetracked. But what I've tried to do is I've tried to put notes up here to keep me on track so I won't get sidetracked with my stories, okay? So I get a little sidetracked, just slap me and get me back in order. So marginalization actually was introduced into nursing by Hall, Stevens, and Dr. Melise. They had written, Dr. Melise was the doctoral chair for Hall and Stevens, and they had really looked, what they had done is they had taken this sociological concept that was written by Dr. Robert Parks back in 1928. He had written a book called The Marginal Man, and it was talking about someone coming from one culture and going into another culture, and how that culture, they weren't really accepted by the culture they were going to, but the culture they were leaving, they had been sort of abandoned. So they were sort of between the two. They were on the margins of both cultures. And that's what the marginal man was about. But Hall, Stevens, and Melise really saw that as the marginal man, as a way of looking at how people get marginalized or get pushed away from the center, and how when they do, they're really getting very vulnerable. So they saw this as a way of working with vulnerable populations, and that's why they brought it into the field of nursing. So it's marginality provides a means for understanding populations at the margins of society that have limited decision-making power. They define the margins as peripheral boundary determining aspects of persons, social networks, communities, and environments. And so it's, marginality is just that condition of being pushed away from that decision-making. I always believe a picture's worth 1,000 words. So I can tell you about being on the periphery, but this really shows it. You know, you've got that center. Stop and think of any community organization you've been in, any work position. You have people who are making decisions. They are the power brokers. And what about those on the outside? How much power do they have? They might have a little, but you know, power usually dissipates as it leaves the center and goes to the margins. You have to understand marginality is being recognized more and more. The agenda for research on women's health really prioritizes research regarding vulnerable populations. And in the vulnerable populations, they really realize that you have to deal with marginalized persons. And according to the World Health Organization, and understanding determinants of health and how these influence marginalized persons, if you understand that, then you can help reduce the health disparities by understanding that. So who are the marginalized? The most marginalized the ones we most commonly think of are usually the homeless, the immigrants, anyone chronically disabled, anyone who's different from the power brokers. And in my research, my vulnerable population are abused women. I've done most of my work. Now, I'm not saying you can't have this problem with men, you know, but it's more common with women, okay? Because traditionally, women have been farther away from the decision making. So vulnerable populations, they experience differential patterns of morbidity, mortality, and life expectancy. For me, marginality was a lens. I saw it more. It clarifies the connection between vulnerability and health for those living distance from the decision making. It served as a lens for viewing physical and psychological health outcomes. Sorry, am I in the break? So what about marginality and health implications? We know that those who are marginalized many times have a much lower socioeconomic status. Low socioeconomic status has been correlated with the marginalized, and we know that those with lower socioeconomic status usually have less healthy resources. And one of the things, as far as those who are marginalized, you have to understand the World Health Organization has recognized depression as the leading cause of disability in the world. And people who are marginalized have a very high risk of being depressed. If we look at, there's a World Health Organization puts out a book called The Global Burden of Disease, and of that, 5 of the top 10 diseases of disability are associated with marginalized people. Also with abused women, okay? So again, these are the marginalized women, people that I was looking at. Depression, alcohol abuse, bipolar mood disorder, schizophrenia, and obsessive compulsive disorder. Now marginality, this is what I'm going to try to get across to you, is marginality is really made up of 7 sub-concepts. That was what really, I mean, I'd read about marginalization before, but when I read this article by Hall, Stevens, and Melise, they broke it down into 7 sub-concepts. And if you understand those 7 sub-concepts, you can really deal with the marginalization, have a better way of addressing it. Now this tells you all about it, but we're going to go through it one by one, okay? So intermediacy, that's just a fancy word talking about boundaries. People have boundaries and borders. Okay, that boundary or borders is sort of like their social connections, but it's also barriers. It can be one or the other. That's one way of keeping in who they are and keeping out those that they don't want to get involved. You know, they don't want them to get closer. So it's both a barrier and a connection, and it encompasses both the psychic and emotional borders. Okay, and that's how it's needed. Those boundaries and barriers are needed because that's how they preserve themselves. They preserve their uniqueness, their autonomy, and their value of self. You know, when the boundary maintenance is well done, then they maintain their self-esteem. But when that starts breaking down, you have a much lower self-esteem. And it aids them in the ability to withstand the stress of social connection. Differentiation is just more or less maintaining those boundaries. You have to understand, center of the society is usually very homogeneous. You know, people usually dress alike, look alike, they talk alike, they have everything in common. Those that are marginalized are more heterogeneous. They're usually outside, you know, they don't really have the social connection, knowing how. It's almost like, sort of like when I went off to doctoral school. I'd been clinical for all those years, and then I went into doctoral education, and I felt like the academia was like a foreign language, and they were talking fast, and I couldn't catch up. Have you ever gone back to school, and it's like, well, you know, I hadn't thought about theory, I hadn't thought about research. I mean, I was in a foreign land, and that's how these people feel. You know, the society is more homogenous. They have all talk about the same. Those on the outside, they lose that connection, and they really don't know how to make that connection. They lack the voice. Well, I'm going to get the voice, okay. Power. We talk about the power. The power is strongest in the center. It can be bidirectional. There can be some power outside on the margins, but the truth of the matter is the strongest power is in the center. And as it goes out, it sort of dissipates, okay? It diminishes as it goes towards the margins. So it's garnered at the center, it minimizes as it disperses towards the margins. But the success of the power structure is really on whether or not the margins are going to be silent, okay? And essentially invisible. If you're silent, you're usually invisible. Okay, so society often encourages invisibility by withholding from powers, positions of power. Stop and think about the glass ceilings. Women go only so high. You know, they withheld those formal positions. And in essence, women were being marginalized by the power structure there in the center. But I talk about that, the power structures. But stop and think, even in your clinical settings, sometimes the nurses have the power, but the patients don't have the power. You're talking a different language, okay? You're busy with your medications, your IVs. The patient is sort of invisible. Stop and think about it. So in essence, it plays out everywhere around you, whether you realize it or not. There are times that you also marginalize someone. And I'm sure there's times you've been marginalized. But anyhow, as a result of all that, you know, in order to maintain those boundaries, in order to maintain some power, these people revert to secrecy, okay? They sort of don't want to tell you anything. They confine their information to themselves, and that's a way of maintaining interpersonal bonds, maintaining their trust, and to avoid betrayal. Now they revert to secrecy to avoid further loss of power. And in my case, when I work with women with a history of abuse, sometimes they become so secretive. They never tell us about that they've had any history of abuse. Just like when I did that exam on that young female in the high-risk OB area. There was nothing on her chart to indicate she had any kind of history of abuse, okay? Many times they're ashamed of the abuse. Many times, if it's happened at a very young age, they've stuffed it down so much that they don't even think about it. They don't even think about sharing it with anyone. But what they don't realize is there can be very long-term problems, you know, health problems as a result of that abuse. They're finding, in fact, I'll show you some of my research, that when you're abused under the age of 12, your health outcomes are much more adverse than people who have been abused before the age of 12. Reflectiveness, and this is really a consequence of all the other traits. These people become and start having a very examined life. You know, they do not necessarily have the verbal skills, and so a lot of times they'll just be quiet. They want to listen and hear what other people have to say because they really don't know how to put forth their thoughts in acceptable verbiage that others can understand and that are not going to be made fun of. Sometimes they open their mouth and someone will make fun of them because, you know, well, that was a dumb way of saying that. Well, to them it made sense, but in your accepted society, maybe it wasn't an acceptable way of doing it. But anyhow, so due to the differentiation, the secrecy, lack of power, they live this life of examine. They're constantly examining, they're constantly second guessing themselves, constantly going over things. And these past traumas are constantly being relived also. And voice. Voice really portrays the marginalized person with a distinctive form of communication. And to me, voice is the essence of marginalization. You'll see this later in my work, but you know, without the proper voice of what the secure center has, you know, these people are sort of pushed out because they cannot verbalize their thoughts as well as someone within the group. They can't, and when they do verbalize it, they may not verbalize it in the acceptable form. And so they lack that ability to verbalize concepts in acceptable terms. Their access to resource and power is reduced because of their inability to verbalize. Stop and think, even when you're taking care of patients again. You know, you can be, they don't have the their medical language to put something in the proper terms. You know, a lot of times it silenced them. And actually, a lot of the work that I do, I look at self-silencing, how women self-silence themselves in order to maintain a relationship. And we do that often without even realizing, whether it be in a relational situation or in a work situation. Stop and think how many times at work you have to bite your tongue. Isn't your tongue a little short these days? How often you'd like to say something and you just bite your tongue rather than say it. So we sort of self-silence ourselves to maintain our position at work also. And liminality, this is a strange word, but liminality just means that these people become very hypersensitive to the world around them. The alteration and intensification of the perception of the world and the world view, these emotional injuries cause them to be even further isolated. So those are the 7 sub-concepts. But in my work, what I really look at is voice and how, again, like how people self-silence themselves. But my thought, and that where my research is always going towards, is that without voice, one's power is decreased, and without power, one's choices are limited. Without choices, one's behavior is restricted. And then choices and behavior are what impact our health. You know, if you don't have those choices, how is that impacting? And to me, it adversely impacts their health. Because I feel that in the shadow of abuse, women are silent. That's sort of been my motivating factor through all my research. One of the studies that I found when I was doing my doctoral workup was this study that really brought it home to me. And this is, you understand, my doctoral work was actually a secondary data analysis of 568 women that originally was a PMS study. And what they were doing was a neurometric. They were testing these women with EEGs and all types of blood tests and looking for different types of PMS groups, okay, the symptoms that put them in the groups. And they had no PMS, they had the physical symptoms, they had the emotional symptoms, and then you had these symptoms all the time. But anyhow, so I was looking at a lot of PMS studies, but this study it really brought home to me, and this was a randomized clinical trial, non-pharmacological, so they weren't given any medicine at all, but it was treatments for severe PMS. But of this group that they studied, 95% of the women reported having had at least one attempted, not 95. Now keep in mind, almost all women have PMS, okay? But of the 95% of women that have PMS, only 5 to 10% have the severe PMS that completely knocks them out of regular work and regular, school, work, taking care of families. And that's what this study was. This was a study of the 5 to 10%, those people with severe PMS. And of that, 95% of those women had an attempted. And that was mind-boggling to me. 81% reported completed penetration against their will. 85% sustained physical threat. But what caught my eye was, again, this self-silencing. 83% had never disclosed the abuse to a health practitioner. Now think what kind of health outcomes they're having from this, and they never even mentioned it to their health provider. And that really, to me, that was how they're self-silencing themselves. So why did I study, marginality, abuse, and health outcomes? Because women in violent relationships are very restricted in how they access, their resources, how they receive emotional support from their family and friends. I thought it was interesting on this Disabled Women's Network of Canada, that of these 245 women, 40% experienced abuse. Now what's interesting is even closer to home, Baylor has a center for women and disability. And back several years ago, they were getting ready to do a study on disabled women and their sexuality. Okay, that's all they were going to look at. And one of their consultants said, don't you think you ought to look at if they've ever been abused? And they at first sort of rejected that idea. Oh, that won't be an important part. But they were a little more pushy on it. And so they included questions about whether or not they'd ever been abused. 62% of the participants had experienced emotional, physical, or sexual abuse in their lifetime. And out of this study, this was the most compelling outcome that they had, is that now they've expanded that in their study. And so they studied it over 10 years in these women that had been disabled. But they almost missed it. They almost were just going to look at sexuality in women and hadn't looked at that abuse factor. It's so much more prevalent. You know, just like when I gave that talk, and of the class of 17 women, 15 either had personal history, family member, or a close friend. That was so close to home. And when I mentioned that, I went back to my little town of Crossville is the little town I was living in at the time, and I said to someone, I said, we need to do something more about this. Can you see how prevalent it is? And they said, shh, we don't talk about things like that. And if we don't talk about them, they'll never be attended to. So that's what has put me on this trajectory of research. So as you can tell, once you get me started, I get really into this because it's fascinating to me. And someone said, oh, why would you want to do that? Isn't it depressing? And I said, if I can save one person, it's worth it all. I mean, if we can help one woman from this abuse, or even help one woman in dealing with the after effects of abuse, it's worth it. Anyhow, so this center, Baylor has taken this as a finding, as a mandate to delve deeper into the causes and solutions of violence among the women who they're studying. So in research, you always say, so what? So why do you do this, okay? You have to understand, the research shows that women are twice as likely to report anxiety and depression than men. Women are 3 times more likely to be sexually abused than men. And my question is, can these disparities be explained further by some gender communication, that women are self-silencing themselves, you know, through it all? So it has put me on a research trajectory for the last 10, 12 years of, you know, abuse, marginality, and health outcomes. Now, I'm not going to bore you with all my research, okay? I know I'm a geek when it comes to research. I love it, and I've put, it's in there what I've done, but I'm just going to tell you that I'll just go over most of it, overview it for you, and that women with a history of abuse have greater health outcomes. I have a questionnaire of 66 different health outcomes, and women with a history of abuse versus, I always use community samples when I do my research. So I look at women, and we don't know who has abuse or who doesn't, so we're looking at both those with and without abuse. And so, but every time I've looked at that is that women with a history of abuse have greater adverse health outcomes, greater anxiety, greater depression, okay? But one of the things about it is in the research, you have to understand, anytime you're going to research something, you have to have a tool to measure it. And when you look through the research, there's no tool to measure marginality. So in my doctoral work, and I told you I had done a secondary data analysis, of those 568 women, all of them had taken this test called an MMPI. I don't know if you know that, but it's a Minnesota multi-personality inventory. And it's used frequently in psychological testing, but it's also used in personality testing. There's 3 types of scales that they have. They have clinical scales, and that's for looking for the psychopathology. But then they also have supplementary and content scales, and that's used more for personality inventory. And so I wouldn't want to pathologize the abused women. We took only content supplementary scales, and those 7 sub-concepts looked for scales that would reflect that concept. And from that, I made a rudimentary, it was rudimentary, but made a scale of a marginality index. Started that during my doctoral program, and through the last 10 years have refined that. Now the MMPI, well, let's see, we'll go on farther. The MMPI is 567 questions. I only used 95 of those for my first measure of marginality. After I graduated and I continued with my research, I distilled that down to 70, but there was still a lot of participant burden because 70 questions is a lot of questions. Well then, someone wanted to use my scale, but they said, you know, there's no way we can have 70. And so I went on and did further exploratory factor analysis, and distilled it down to about 15, but someone said, no, I want it lower than that. And so I distilled it down to 5 items. Now that 5 items, can you imagine? So I held my breath the first few times we did research with it, because I was fearful. Initially, you understand, when you do research with a new tool, you want good reliability. So anything over 0.7 is good reliability. Well, in my 70 items, I was able to get 0.96 with every one I did. I'd done a couple studies that got 0.96. But when I went down to 5 items, I was fearful that we were going to lose all that. I still have 0.84 to 0.91, which I'm really pleased with, only 5, okay? So I'm still excited about it. And as a result of being able to make it more workable, it's now been translated into Spanish, Russian, Ukrainian, Tagalog for Filipinos, and then French Creole for using down in Haiti that they've taken down there. So it's been exciting to be watched, but I just stand in awe, you know, how life changes. Who would have thought this little kid who graduated from nursing school and just wanted to be a good med-surg nurse gets to have the fun of doing all this research. Anyhow, just bear with me. Like I said, I get real excited when I do this. This is just some of the marginality significantly correlated with all the abuse. I looked at childhood abuse, adolescent. It was interesting. Even though the person who initially did this research study of 568 women, they were mostly focused on PMS. But when I went through that, they had also asked 100 questions about abuse. They divided it under the age of 12, 13 to 19, and then 20 and older. So you got childhood, adolescence, and adulthood. Okay, and that's how I looked at it. But marginality significantly correlated with all forms of abuse and all age categories and types of abuse. And I looked at sexual abuse and physical abuse. And marginality was a significant predictor. If they were more marginalized, they were abused under the age of 12. And that was a very significant finding in that. When I looked at the PTSD scores, I thought was extremely important. Look at this. If they, and you understand, I just gave 1 point. At this point, they were I had cutoff scores for each of those. And so if they either got a 0 or 1, so if they had 0 to 2, which was the majority in that sample, their mean PTS score was only 9.2. Okay? But look incrementally as it goes up from 3 up to 7. 9, 14, 17, 23, 20. The more marginalized they were, the higher the PTSD scores, which I found to be very significant. This just is telling you that, talking about only 2% of the no PMS groups were sexually abused, but I have a better picture. This shows a lot better, okay? For women who had no PMS, only 2% of their sample had been abused under the age of 12. Physical symptoms, about the same, okay? And above 12, 1% with no PMS, 3% for physical symptoms. But look at the emotional symptoms. Instead of 2%, 20% had been abused under the age of 12. 10% abused over the age of 12. Those presenting with PMS with emotional symptoms had a much higher incidence of abuse. Then I went on to look, and then I added to my research a scale put out by Dana Jack several years ago called Silencing the Self Scale. And it looks at how women silence themselves to maintain relationships. And again, I was testing this marginality index, and I had a good reliability in that. But there was a greater perception of being marginalized and being self-silenced were always associated with greater depression, greater anxiety, and more numerous health outcomes. Those 66 health outcomes I asked about. I did it again. First one was just a pilot study of 50 women. Here I increased it to 244, and just almost identical. Identical as far as the reliability of the scale, and identical as far as the outcomes, the health outcomes. This is just my marginality scale. It's not copyrighted. If any of you are doing research and want to use it, you're welcome to use it. I just would like to know what your results are. Okay, just 5 simple questions. Number 4 has to be reverse scored. Otherwise, the higher the number they get, the more marginalized. And you understand, from all that, I'm also going on to do more research, and the marginality index is used as part of, I'm in a research team with a researcher out of San Diego and out of Savannah, Georgia, and we're working on looking at instruments that can be used globally. We'd like to see, what we're working with is mission nurses, go out on a lot of mission, do a lot of mission work, but they're not researchers. And we're trying to give them tools that they can also do research to continue, and to find outcomes. And if you can find outcomes, you can improve your patient's health. So we put this functional assessment for interventions in the healing practices in women globally. It's 6 clinical assessment tools that we use, and looking at social support, looking at self-esteem. Marginality is in there. We look at role quality as far as your role as a wife, mother, worker, that type of thing. So we're working with this. We've had good reliability. This has been being used in Tagalog, in a Filipino group. It's been used in a French Creole in Haiti, and then in the Ukraine. And it's currently, we don't have the results. We'll have the results this month of a Japanese group that's using it also. It's been just recently translated into Japanese. But anyhow, this is measures correlated with physical and mental health for global use. It's based upon the socio-anthropological, I will say it, conceptual model. It's based on Linda George's transitions for women. I just sort of told you that already. But anyhow, we've pilot studied it, plus we've done focus groups to see how it works within these different groups. So my goal for marginalized women, especially, and I say women, but this is for the marginalized, is that with voice, power may be increased. With power, more choices are available. And of course, with more choices, your behavior is always positively impacted to make better decisions regarding your health. I'm all for voice, because I feel like voice is a verbal opportunity for creative expression. Without voice, we have no creativity to our lives. And so that's my focus, is how do we help people find their voice? So often people are silenced in many ways. Transforming the marginalized, how do we transform them? We do that by sharing our knowledge, and not from I'm the teacher and you're this lowly student. You share on an equal type. And for that, it's amazing how this all happens, but this is a model I developed back in the 90s. Again, when I was in my master's program, I was taking this class, and they said, you've got to synthesize everything you've done in this class. And as a result, I developed who I am, or who I believe a person is, okay? I think we're all spiritual. We're body, mind, and soul. And so as a result, I developed this spirit model. And of course, our spirit is the center of who we are. And from that, we have different power strategies as to how we deal with the outside world. And how we deal with that impacts our emotional health, and our emotional health in turn impacts our physical health. People who try to treat only the physical without attending to the spirit and the emotional are missing 2/3 of the picture. We've got to look at the whole in a holistic manner as to how these people work. And they work by spirit, mind, and soul. I mean, mind, body, and soul. So it's physical, it's emotional, and it's spiritual. So, let's see. So the strength is, well, you can almost not quite see it, but from each of those strengths, I've developed, we had hardiness, and this is developed, when I did a lot of my reading, my background reading, I looked at Aaron Antonovsky, who looks at sense of coherence, Suzanne Kobasa, who looks at hardiness, how people, you know, some people go through stress and they just come alive. Other people go to stress and it kills them. And what's the difference? And so Suzanne Kobasa did a lot of work looking at, you know, the A-type personality. Why do they flourish and someone else just crumbles in the face of stress? And so based on that, and then also Judith Miller, who works, she's written a book called Coping with Chronic Illness, Overcoming Powerlessness. How people who are chronically ill and how they become so powerless at times. And so she talks about these strategies, and I've adapted that some within the Antonovsky and the hardiness with Kobasa. So the strength is hardiness. The power strategy to do that is commitment, okay? And so the intervention we'll be working on, I have, you know, this is an area we're just beginning to work on, is the interventions in order to attend to these different power strategies. So we'll be looking at social support for that, self-esteem, the power strategy is worth, you know, how worthy do I feel? And we'll be looking at self-efficacy. Motivation is opportunity. If you're motivated, that gives you so many more opportunities. We'll be looking at how nurses have, there's a technique called motivational interviewing that really, it attends to your patient and really is in a positive way of, while you're interviewing them, you're also encouraging them. And then as a result of that, you have knowledge, control, and empowerment. We have an empowerment scale that we'll be using to help empower these women. Faith, our faith gives us purpose, and that purpose gives us hope. And I'll be using the Miller Hope Scale for that. And then physical strength is endurance, and we're looking, in fact, we already have one of our studies looking at lifestyle physical activity. So, anyhow, that's sort of the end of my talk. This is a quote. You understand it, up in Appalachia, our health system was sort of founded by this Dr. May Craft. She was a woman who actually moved to the area back in 1929. I mean, talk about rural. Our area until 1960, where I lived, until 1960, when they put the interstate through, this area was very isolated. I mean, very isolated. It was up on a 2,000-foot escarpment, very poor roads, and people didn't go up those roads unless they had to, okay? And so this area was very isolated. They had an academy for the children for school, and the American Baptist Association started this academy to educate the children because there were no public schools at that time. Anyhow, Maycraft came there, even though she was a medical doctor, she came there as the wife of the principal for this academy. And then he died shortly after they got there, but she stayed and started with building the health system in that area. And really, our wonderful hospital was a result of all the work she had done. Well, in her autobiography, she had this quote that I just love. And it says, "What a blessing it is to be able to give stricken people the help they need to solve their own problems. It is our duty to help the weak, but it's our pleasure to give a helping hand to the struggling fighter." And people in the rural area, in those very isolated areas, are very independent, struggling fighters. And she gave them the help with improving their health. In my area, patients with the potential for being marginalized are struggling fighters. And through my research, I hope to give them the helping hand and help them find their voice. So that's marginalization. And if you like to know it a little better, do you understand? If you understand those 7 sub-concepts, I mean, you're going to be amazed as to how often you see marginalization. I was in this committee meeting, and I mean, you could just see the power broker, you could see the power in the center, and people just almost sit out. You see them sitting towards the back because they know they have no power in the center. But anyhow, you'll see it everywhere. Yes, sir.
And you work mainly with women? I mean, that's you work like, I work with mental health.
absolutely. Mentally ill would be one of the vulnerable populations. All my work so far has been with women. I'm a family nurse practitioner, but when I went back to get my master's, I became a women's health nurse practitioner because so much of my practice was women's health. But, I mean, it can be used because they are a vulnerable population. Oh, I'm sorry.
I didn't know whether, has anybody done anything with this index?
Oh, no. So far, my index has only been used with women, yes. But, I mean, anyone who's willing to do research, just keep posting. Anyone else have questions?
Have you used your index? Has it been used with women who've not been abused, different kinds of marginalization, different kinds of vulnerable groups of women?
My index has been used with community samples of women, okay?
Uh-huh.
So I look at both women with and without a history of abuse. And then I look at their health outcomes. Currently, I'm part of a research team that we're funded by the Houston Endowment, and we're following 300 women. 150, they've all had abuse, and it's first-time abuse. 150 of those women went to a shelter initially. They and their children went to a shelter initially. And then 150 of those, another 150 had gone to, they were community-based women. They went to get a protection order. And then we're following these 300 women, 150 from each of those groups, and we're following them over a 7-year period. We've already followed them for 2 years. And so far, my marginalization index has been very good. And we have an 84 internal consistency, and it showed, and from the sheltered women are more marginalized than the community dwelling women, which intuitively I would have thought that would be the answer, but it's always good when research supports your intuition. And then the women who were U.S. born were less marginalized than the immigrants who have documents, and the immigrants with documents are less marginalized than the immigrants without documents. So again, that's what I'm working with. Okay?
This is lost.
It's so
You
exciting.
even hear somebody talk about, use the language around marginalization. Because when we're talking about vulnerable populations and disparity of health, that's it.
Well, it's everywhere around us. I saw a hand over here. Yes, ma'am. Okay. We have to go back to that. Functional assessment. It's in your, oh, that's right. I tweak my talks all the time. And you understand, I had my talk like it was, I had one of my research friends look at it and she says, they're going to get so bored with you, all that researching. Drop that and add something, add your newest work to it. So that's where I came up with the, I'm sorry. I did, I added that last night, I think. But anyhow, see, I get sidetracked. I get so into my, okay. Functional assessment for interventions in the healing practices in women globally. Okay, that's what we're. Any other questions? Well, I hope you enjoyed marginalization as much as I. Thank you.